published a paper together for the chronic stimulation on the
Absolutely.
The dystonia. So
absolutely.
there we have seen the patient with the first 3 months and the same patient after 1 year and after 2 years, after 3 years and up to 7 years. The improvements getting better and better as the stimulation is getting in the chronic.
But they will still see an effect. Probably sometimes they will see an effect before
earlier,
3 months.
Yes, and maybe out of 10, 2 patients we can see earlier.
That's right.
Maybe patients need to see after 2 or 3 months. So in your depression also you see the same way?
Some patients there have been some patients that we didn't meet response criteria within the first year, but then did after year 1. That's not the norm. But so it's and unfortunately we're still not able to. All depression is not the same, and that's the difficult thing. Just like dystonia, you can probably choose similar classes of dystonia to choose DBS and then study them. But in depression, we are less restrictive on our selection. It's a very strict selection criteria, but there's different types of depression that we're grouping together. And so the patients that respond quickly versus the patients that are a little bit delayed, we still classify as treatment-resistant depression, but they may not be the same disease. So it's very unfortunately, we don't have enough numbers to know what's different about this person versus this person. And we can see, where the structural tractography has, if there's different changes. We can see functionally there are changes, but we don't know specifically why that person may have a more delayed response.
And have you seen the patient after 2 years or after 3 years, they're without any improvement, or every patient has improved?
No. We have definitely had patients who have failed improvement, and those were pretty within our the series that we published of 10 patients, our first 10 patients.
So those who didn't improve at all, so what do you suggest? Stimulation to be continued or of the stimulation?
Some of the patients did not want stimulation to be continued. Some wanted explanted. Some patients don't have it explanted and just have it turned on. So I would say they don't improve. So let's say this. They don't meet response criteria. Response criteria is 50% improvement.
Match the criteria.
Correct. They improved to 30% improvement, which is somewhat of improvement. Sometimes they don't find that it's they look for they're not massively changed, so they say that they're a little bit better, but they still don't like it. But there's not a person who has had zero response.
There is no zero.
There's no zero.
So there is improvement, but their expectation was different.
Correct. And that's the difficult thing with DBS in general for all diseases, that making sure their expectations are met, that we are going to help them or try our best to.
And for this MFI with the medial forebrain bundle, you use the Medtronic, the directional lead or the non-directional lead?
So most of our patients were implanted before the Sensite directional lead came out. So these patients have been implanted just with 3389 leads. Since the Sensite lead has come out, which was a year ago, and I think that those patients certainly have been, but it was not available prior to that. So we've had, I can't remember how many patients we've had.
Sensite leads or the 3389, the non-directional lead?
We have not used the directionality yet on these patients, but it is there. So the directionality we find could be important, say if we had a patient that had a side effect at stimulation that we could then avoid. But we haven't had that need to do yet. So the patients that we have had with directional leads implanted, we've just used ring modes. We don't have enough data, enough patients to really support is changing the direction going to improve, because they've improved on just ring modes without side effects. We have had no need to use directionality. Interesting, though. It's definitely something out there that we want to try.
No, I did because I wanted to know directional lead and non-directional lead, how is going to help.
I'd rather have the directionality ability. But if we don't need to use it, we don't need to use it. If we need to, that's great.
But you use for directional lead for the movement disorders, for the Parkinson's and all the.
Usually, yes. Again, only if we can't get a high enough threshold for a clinical improvement when there's a side effect. So if we start seeing dysarthria, or we see a little bit of a internal capsule involvement.
Besides, this patient will need directional lead or non-directional?
The programmer.
Or the neurologist.
The person who's programming is typically the neurologist.
Okay. So, but you put the Sensite leads, but first maybe he uses a non-directional. Depends on these things, he put it in a directional.
That's right. And but we usually check during surgery, we evaluate if there's going to be a threshold response and if there's going to be any side effect threshold. So if we check to say 5 milliamps or 5 volts, then we're going to, hey, the patient has no side effects, this is great, then maybe they shouldn't have it during when it's stimulated when they're on.
So on table itself, as to put directional or the non-directional?
We always implant directional. So in the United States, if we're using Medtronic, say, or any device, we can only implant directional. They do not support, no device company supports non-directional leads anymore.
Okay. So anyways, it has to be directional.
It has to be directional. Whether you use it or not,
that is up to you.
That's right.
But it has to be directional.
Yes.
And apart from Medtronic, have you used any other companies' devices?
So when I was in Houston, Medtronic was definitely dominant, and I very much like Medtronic, but I'm open to using other devices, and so we'll see what happens in New York.
So New York, in so many, whatever surgeries you have done in last 2 months, so it's all Medtronic or something?
It's been Medtronic for DBS lead placement, but the batteries changes have been every company, but we will see how, as time goes on, what exactly happens.
So far you use about or most?
Again, not for DBS lead placement, but I've only been in New York for 2 months.
No, I was thinking that if you put the complete set of Boston, the electrodes and also the battery, and to compare which is giving you the best outcomes.
So I don't really think that there's going to be any outcome difference regardless of the manufacturer. There shouldn't be. There's no difference. The electrode is the same. It's the surgeon placing it in the territory in their brain and making sure that everything is perfectly done that is most important. The directionality is useful for suboptimal placement in the brain and for when a patient has some really difficult programming, but that is not ideal. And so if you look at, say, if a surgeon is qualified and can implant an electrode well, when we look at what does that device do for them? Abbott and Boston have limitations on their 3T imaging post DBS. Medtronic, you're able to image with 3T MRI post DBS.
In Boston also they do. They have a 3T MRI with MICC.
Not with your brain, not brain. You cannot get a post. You cannot get a post DBS MRI with Boston with 3T. You cannot. And you also can't have your DBS on during MRI. In Medtronic, you can have it on. And so the other ability that I like for Medtronic is that you have the ability to use sensing through the leads with the Percept battery. Well, Percept battery is Percept PC may not be available in India, but it is definitely available. It's available. Okay, great. Well, that is the only primary cell that is available in the United States. And so when you have that in a combination with the Sensite lead, or even with the old leads, you have the ability to sense. And sensing is really important because if we know that as Parkinson's disease, there's some beta oscillations that are pathological. And so if we're looking at those beta oscillations, we have the ability to suppress them with stimulation. That's what causes clinical improvement, what we believe. But say the area that has the highest beta oscillations in the STN, say for targeting for Parkinson's disease, that location may not be constant throughout time. So say after surgery, we implant an electrode, right? And we're stimulating at contact 1. Has the best improvement clinically, also has the best beta suppression. Say in a year, patient comes back, you do some sensing, and now contact 2 is really the one that causes the best beta suppression. And the patient's doing reasonably well, but there's always a combination of medication, stimulation, not really sure what the optimizing of the stimulation does for the patient. Well, if you switch to contact 2, say, maybe that patient could even have a better response than what they ever knew. And sometimes these things escape the practitioner when they're applying stimulation because you see an improvement and it's good, but you don't really know how to make things better. And so these are extra guides that can help you say, okay, well, this is this is a matter-of-fact guide, a quantitative improvement that you can look at objectively and say, okay, this is something that we're doing in response to this patient's clinical exam with medication changes. Kind of gives you just more information about how you can make the best outcome for a patient. And so that's one thing that's very interesting about Medtronic. It's a new way of thinking. because not any the other device companies don't offer that. But even within Medtronic, the people who've been just using that, it's new to every practitioner. No one really has used this over the last 30 years. So it's very interesting. It's a new way to think.
And apart from DBS, are you involved with any other neuromodulation currently, or you are planning to start?
Myself?
Yes.
So for the last decade, I've done a lot of spinal cord stimulation, specifically for pain, which is very common in the United States. And so I definitely will be doing some more of that in the near future.
Spinal cord stimulation.
Spinal cord stimulation, that's right.
And DBS for any other new the neurological or psychiatric disorder you're planning for to do start?
So DBS for epilepsy has been approved for the last couple of years.
It's also FDA approved for DBS for epilepsy.
That's right, and so do DBS for epilepsy as well.
So you started doing it?
Well, we started that in Houston. Hope to continue that in New York.
So the addiction will be the new one you're planning.
Well, right, that's something that would be extremely exciting to do. And, in the United States, that would be has to be done under an FDA-approved clinical trial. So very select centers and under specific criteria could do that. And that's something that I would very much look forward to trying to see how that would work in here in India.
Because here we are trying to get some at least trials on these addictions. And for DBS, like it's not only the alcohol, it can be opioids or it can be alcohol, any addictions.
Right.
We're trying to do it, but it has to be failed the treatment resistance.
Select criteria, it's very specific inclusion criteria, but definitely treatment resistance.
Right.
And they also just say, hey, well, this in the burden to society, how much this can improve a patient's